Hello, it's a pleasure to be speaking with you again about therapeutics for COVID-19. In today's talk, I'm going to focus on antibody therapies for COVID-19. These are my disclosures. In covering antibody therapy, I'm going to speak first about convalescent plasma and then about monoclonal antibodies. So let's start with the discussion of convalescent plasma. Convalescent COVID-19 plasma, or CCP as it's often abbreviated, is taking plasma from survivors of COVID-19 infection that may contain high titers of neutralizing antibody. These antibodies can then be administered to individuals who are suffering from COVID-19 or potentially as a preventive to protect against the acquisition of COVID-19. This therapy can be given as whole plasma or as purified immunoglobulins, or as we'll get to in the discussion of monoclonal antibodies, individual SARS-CoV-2 specific antibodies themselves. Convalescent plasma has shown some benefit in the treatment of avian influenza and in H1 influenza, as well as MERS. And pilot studies and uncontrolled trials in COVID-19 have suggested a possible benefit of convalescent plasma. The first of these studies to be published was an uncontrolled pilot study in just 5 individuals in China, suggesting a possible benefit of CCP in patients with COVID-19. Notably, these were 5 intubated patients, 4 of whom were subsequently weaned off the ventilator. This paper published earlier this year in JAMA showed that, first of all, the virus load was reduced, as you can see, by the increasing cycle length needed for a positive PCR test. The clinical acuity score, or SOFA score, declined in these patients. Their oxygenation improved, and they also became less febrile. Of course, there's not much one can conclude from just 5 patients in an uncontrolled observational study, essentially. And this phase 2 open label study that was a randomized clinical trial, albeit still relatively small, failed to show any significant difference overall. This was a study done in 5 medical centers in Wuhan. It had 103 participants who were randomized equally between convalescent plasma and standard of care. Notably, in this study, the plasma selected for infusion had been pre-screened to have high titers of IgG specific for the receptor binding domain of the spike or S protein of SARS-CoV-2. Not all convalescent plasma studies have actually used pre-screened units, so that's a unique feature in this trial. The primary endpoint was time to clinical improvement within 28 days of treatment. You can see in panel A that although there was a slight improvement in terms of the improvement rate for those who received convalescent plasma, there was no statistically significant difference between those who received the plasma and the control patients. However, among those who had severe disease, there was a statistically significant difference in the rate of improvement for those who received convalescent plasma. This was not the case, however, in those with more severe or life-threatening disease, essentially patients who were on mechanical ventilation. A somewhat larger experience, but this from an uncontrolled study, reported interim results of convalescent plasma use in the Houston Methodist Hospital system. These were all patients with severe or life-threatening disease. They received 1 or 2 units of CCP, and they were then matched to controls, but not a randomized control group, by propensity score matching. And they went through 2 rounds of matching, and that's why these graphs all refer to secondary matched patients. There were 136 patients who had received the therapy and 251 controls. Overall, again, while there seems to be a numerical advantage in terms of survival, with only 3.7% mortality among the transfused versus 7.6% mortality among the control group, this difference did not achieve statistical significance. Similarly, if you look just at those who received convalescent plasma within 72 hours of hospitalization, there was again a numerical difference favoring transfusion of CCP, but that again missed being statistically significant. If you looked at all of the matched patients who were transfused more than 3 days after admission, there was no difference at all. But if you look very specifically at the matched cohort and focused only on those who were transfused within 3 days of admission and received high titer plasma, recall not everybody had a pre-screened plasma, these were retrospectively screened, then you saw that there was a substantial difference, only a 1.2% mortality among the transfused patients and 7% mortality among the matched controls, which just made statistical significance. A much larger experience comes from the expanded access protocol that was being administered by the Mayo Clinic. This was really a nationwide program that made convalescent plasma accessible to providers and patients at centers that were not doing randomized controlled trials with convalescent plasma. This became a much larger program than anybody really envisioned. And this interim report that is still only posted on medRxiv and has not yet been peer reviewed details the experience with more than 35,000 patients who received convalescent plasma, again, unscreened units. More than half of these were patients in the ICU, and more than a quarter of them already intubated when they received convalescent plasma. Overall, and here they're just comparing either results based on time of infusion or titer of the antibody determined retrospectively. The 7-day mortality for those who received convalescent plasma within 3 days of admission was lower than those who received convalescent plasma 4 or more days later. You can see just under 9% versus just under 12%, a roughly 25% improvement in mortality, which was statistically significant. Likewise, the 30-day mortality again showed about a 25% improvement in mortality rate, going from nearly 27% to just under 22% for those who received convalescent plasma earlier versus later. But these are not controlled results because there is no placebo group. And if you look at the same groups of patients, and now here in the top row, the 7-day adjusted mortality, and the bottom row, the 30-day mortality, examining the titers of antibodies, and I apologize for the print here being a little bit fuzzy. We're comparing the mortality in those who received low, medium, or high dose, high titer convalescent plasma. You can see that there's a very clear gradient of effect, with the lowest mortality among those who received the plasma with the highest titers. None of these differences actually reach statistical significance, however, because the confidence intervals cross 1. And then if you further look at those who received high titer antibody within 3 days of admission and compare those to the participants or patients who got medium dose or low dose, again, you see a bigger gradient of effect. It was, but still not, and it was statistically significant when you compared the low to the high dose, but not the medium to the high dose. Another analysis of this convalescent plasma was done actually by the FDA using data based on neutralizing titers determined by the Broad Institute in Cambridge, Massachusetts. In this analysis, the FDA found no difference in 7-day mortality overall, comparing high versus low titer CCP. But there was a 21% reduction in 7-day mortality among non-intubated patients who received high versus low titer convalescent plasma. And the difference in these two analyses is the first was all comers and the second is limited to those not yet critically ill. And that was a statistically significant difference. There was no association between CCP titer and 7-day mortality among intubated patients, hearkening back to those preliminary phase 2 data that I showed you earlier from China that demonstrated no benefit of convalescent plasma in critically ill patients. However, if you limit the analysis to non-intubated patients under 80 years of age who received high titer convalescent plasma within 3 days of admission, there was a significant reduction in 7-day mortality, nearly 50% reduction, and that was highly statistically significant. On the basis of these data, the FDA issued an emergency use authorization allowing the administration of convalescent plasma and bringing to an end the expanded access program. So to summarize the information about convalescent plasma, anecdotal evidence and uncontrolled trials suggest convalescent plasma may provide benefit in patients with severe COVID-19, particularly when patients receive high titer plasma within 3 days of admission. There's little or no benefit in critically ill or intubated patients. But it's important to note that the data to date don't prove a benefit, and randomized trials are still ongoing. There are many such trials going on across the world. The Infectious Disease Society of America guideline panel recommends COVID-19 convalescent plasma be used only in the context of such clinical trials. And the US Department of Health and Human Services COVID-19 treatment guidelines state there are insufficient data to recommend either for or against the use of convalescent plasma for the treatment of COVID-19. Convalescent plasma should not be considered standard of care for the treatment of patients with COVID-19 at this time. Well, let's go on to discuss monoclonal antibodies. Monoclonal neutralizing antibodies can be compared to convalescent plasma in much the same way as a single malt scotch might be compared to a blended scotch. I'm sure Dr. Shapiro will appreciate that analogy. Human monoclonal antibodies are able to neutralize a wide range of SARS-CoV-2 isolates. They all target the S or spike protein, and they can enhance various immune effector functions such as complement-mediated lysis, antibody-dependent cellular cytotoxicity, and cellular phagocytosis of infected cells. These antibodies can also be genetically engineered to combine multiple specificities or to extend the half-life of the antibodies. There's potential utility of such antibodies for both treatment and prevention of COVID-19. One of the reasons that monoclonal antibodies are now so widely available is that the technology for developing and mass producing antibodies from B cells that respond to any particular antigen has improved enormously over the last 1 to 2 decades. And there are 3 basic ways by which monoclonal antibodies can be made. I'll just very briefly summarize these. Essentially, you start with a patient, or in some cases, an animal that is immune to the antigen of interest, here the spike protein, and you purify their B cells. Then you can either immortalize those B cells and screen them by limiting dilution for which cells are making high titer or highly neutralizing antibody, and then clone the gene out of those cells. You can just randomly clone all of the immunoglobulin genes and then express those genes in a phage library and identify which phage clones are actually producing antibodies that bind the protein of interest. Or you can sort the B cells by flow cytometry using the, in this case, the spike protein to capture those cells that bind with high affinity the spike protein, and then clone out those cells and clone out their genes. And from there, you can go on to produce a monoclonal antibody of high specificity. Now, we know in the case of Ebola that monoclonal antibodies were actually highly effective. They had a much lower mortality in a randomized clinical trial, with only 30% mortality in the participants who received either of 2 different monoclonal antibodies compared to mortality in participants who received either remdesivir or the ZMapp synthetic antibody. So there's good hope for thinking that monoclonal antibodies might have an effective role in the treatment of COVID-19. This slide shows some of the preliminary preclinical data on one of the monoclonal antibodies. And here, this 3-dimensional diagram shows you the monoclonal antibody with the heavy and light chains shown in purple and pink. Here you see the receptor binding domain of the SARS-CoV-2 spike protein, both the internal and external components. This is the part of the receptor binding domain that would engage the ACE2 receptor. And you can see how binding by the antibody to the external domain of the spike protein obstructs the ability of the natural receptor ACE2 to engage with the virus. And here on the right-hand side, we see two different monoclonal antibodies. The one in red is the same antibody as that pictured here on the left. And you can see that there are really very high, there's very high activity with EC50s in terms of neutralization of less than 1 microgram per mil. These antibodies are also quite effective in treating or preventing COVID-19 in the rhesus macaque model. Here you can see the control animals are shown in black here. This is a virus titer. Those who received the antibody pre-exposure are shown in red, and those who received the antibody as treatment are shown in blue. And you can see the red prevents infection, the blue leads to a rapid reduction in virus titer, and as compared to what happens with natural infection. And then in the lower panel, you can see these sections of lung, the histopathology for the control, where you see extensive inflammatory cell infiltrate into the alveolar spaces, and in this trichrome stain, extensive fibrosis of the pulmonary interstitial spaces. And fibrosis, there's, I'm sorry, in the pre-exposure animals, there's not complete prevention of lung injury, but it's certainly much improved compared to the controls. And here in the post-exposure, that is the therapeutic application of the antibody, again, you see, although there's still many inflammatory cells, there's much better preservation of normal lung architecture and much less extensive deposition of collagen in the interstitial spaces compared to the controls. So we only have limited data in humans from two sets of monoclonal antibodies so far. The Lilly antibody, LY-CoV555, was studied in the BLAZE-1 trial. This was a placebo-controlled phase 2 study in symptomatic outpatients with COVID-19. 3 different doses were studied: 700 milligrams, 2,800 milligrams, and 7,000 milligrams, or 7 grams, which is a lot of antibody. The change in virus load endpoint at day 11 was met for the middle dose group, but not for the lower or higher dose groups, which is somewhat puzzling and may relate just to the very small numbers in each of these groups. Emergency room visits and hospitalizations occurred in 5 of 300 participants who received the monoclonal antibody versus 9 of 150 placebo recipients, which was numerically better, but not statistically significantly different. There were no study-related drug serious adverse events, and viruses with putative resistance mutations emerged in 8 of the treated and 6 of the placebo participants, so no clear evidence that there was selection of resistance by the antibodies themselves. Additional trials in inpatients, outpatients, and for prophylaxis are currently ongoing. Now, because we know that resistance might emerge, one could ask whether combinations of antibodies might be better than single antibodies. And a combination of 2 antibodies being developed by Regenron has been studied in rhesus macaques and also now in human preliminary trials. In the macaque experiments, which are illustrated in this slide here, you can see that this combination resulted in dramatic reduction of virus load in the animals compared to placebo. And again, if we look at the histopathology, you can see here the placebo group shows accumulation of a large number of inflammatory cells, and then there seems to be a dose response, with the monkeys getting the highest dose having essentially normal lung architecture with very nice wide open alveolar spaces. Those that receive the lowest dose have significant inflammatory infiltrates. So the Regeneron antibody cocktail has been studied now in an ongoing so-called seamless phase 1, 2, 3 trial, where they initially did the pharmacokinetics and then moved on into a phase 2 study and are now expanding into phase 3. The results of the phase 2 study have been posted by a press release that involved 275 outpatients who were randomized to receive either 8 grams or 2.4 grams of this cocktail or placebo. Notably, the participants were stratified retrospectively by the presence or absence of their own antibodies at the time that they were administered the cocktail. And it was found that serologic status correlated highly with baseline virus load. That is, people who were seronegative had much higher levels of virus compared to those who were already seropositive. There was about a half log greater reduction in participants who were treated with the high dose and a quarter log reduction in patients receiving the low dose as compared to placebo. The high dose group, that was a statistically significant difference, but not so for the low dose group. These differences were slightly greater when limited to those who had not yet developed their own antibodies. Among that seronegative group of patients, the median time to symptom alleviation was 13 days in the placebo group compared to 8 days in the high dose and 6 days in the low dose group. Neither of those differences was statistically significant, and it's a little curious that the low dose group had a quicker time to resolution of symptoms, just demonstrating that you really can't draw clinically meaningful conclusions from small phase 2 clinical trials. Both doses were well tolerated, and additional inpatient, outpatient, and prophylaxis trials are ongoing. I have to comment, of course, that it was the 8-gram dose of this particular cocktail that Donald Trump received when he came down with COVID-19 1 week ago. So in summary, numerous SARS-CoV-2 monoclonal antibodies have been produced. These monoclonals reduce virus load, may protect against infection, at least in the macaque model, and reduce injury to the lung in animal models. Multiple human clinical trials are ongoing for treatment and prevention of COVID-19. Preliminary results of phase 1/2 trials with the LY-CoV555 antibody and the Regenron CoV-2 cocktail are encouraging, but we still need randomized clinical trials. There have been no safety concerns to date, but phase 3 data are really needed to demonstrate clinical efficacy. Thanks very much, and I'll turn this back to the moderators.